Hello, students. Welcome to chapter 20, Diabetes Mellitus, part 3. And right now we're going to talk about the oral and non-insulin injectable medication. So basically, this is the beginning of the treatment, right? We start with the algorithm. Some of them, they're going to start with lifestyle changes. Others, they are going to start with metformin, which is the part one, the initial therapy, right? So let's review some categories. You have the A-glucosidase inhibitor, your acarbose, migritol. It slows down an absorption of starches, thereby delaying the rise in blood glucose level that occurs after a meal, right? And then you have your B1-ide, your metformin, suppresses the hepatic glucose production, and this medication works in the liver. So you have medications for each organ that is participating in the diabetes balancing, right? For example, the Simlin number 2, suppresses glucagon production. This one, for example, works in the pancreas. And then some other common medications. You have your Byetta, improves the glucose dependent secretion of insulin, decreases glucagon secretion after eating. This is an injectable medication, okay, Byetta. Is different from Ozempic. The other one is also used not only for in cases of diabetic patients, but also to lose weight, okay? And that's it. And what else? We have this one, your Jardiance is your sodium glucose transport protein inhibitor, blocks and thus reduces the reabsorption of glucose in the kidneys, extra glucose release in urine. But the side effect of this medication is that causes urinary tract infection, and is because the amount of glucose that is released used in the kidneys, it's a good amount. It's a good amount. Now we have another one very common is your sulfonylurea, second generation. So this is a derivative of your sulfa medications. Okay, so patients sometimes that are allergic to sulfa antibiotics, probably they shouldn't be taking glipizide. Okay, increases insulin secretion from B cells, right? It works on the pancreas. So you have this regular presentation, and also you have the extended release, because this medication is going to make your pancreas work very hard. So that's when the extended release is going to prolong, the participation of the production, but it's gonna make it in a slow progression pace. Okay, so those are some medications. Also you have your Avandia. This medication, for example, is also well known to increase insulin sensitivity in muscles and fat. So you see different type of areas where these medications are working. Okay, so this is a thiazolidinedione, is a drug class, but you are going to hear about them basically with the brands sometimes in your clinics. You have drug nutrient interaction. Common side effects for the medications includes, they are talking about your CGLT2 inhibitors, include polyuria, hypotension, dizziness, genital infections, and increased risk for urinary tract infections, right? One specific medication in this class increases the risk for lower limb amputation and fracture. And this is very dramatic. So sometimes, this is, you see, the one that I mentioned, your Jardiance, is very popular. So causes the UT, urinary tract infection, and within in this category, this is the one that the doctors prescribe the most. You have your Farxiga, your Invocana, your Steglatro. I think Invocana had a good marketing in TB, but you have to consider, right, the urinary tract infections and also the risk for lower limb amputation and fracture. So if you know any family member that is being prescribed this medication, that's your responsibility, right, to teach them about this. So there are four critical time frames when the diabetes care and education specialists should provide diabetes self-management education and support. The book is saying that there are four critical time frames to provide education and support. Number one is a diagnosis, right? Number two is during the annual assessment of education, nutrition, and emotional needs. Number three, when new complicating factors influence self-management. And number four, when transitions of care occur. So at diagnosis, the patient is going to be very affected at the beginning. Some others, since they don't see, they don't feel the complications, they are going, oh, okay, I'm gonna lose my consumption of carbs, I'm gonna start my diet, right? Number two, during the annual assessment of education, nutrition, and emotional needs. So patients start getting more scared about the condition when the doctors start bombarding them with medications. Okay, so okay, you took your metformin, let's say 500 is the initial therapy. Now I'm going to increase to 1000. Now I'm going to add another medication. And then if your sugar is not well controlled, let me add a third medication. And then let's start insulin. So that's when they start paying attention, if they pay attention. Now you have to address also the environment in which the patient is living. Who are the relatives, the family member? Are they willing to cooperate with the nutritional needs of the patient and the lifestyle changes? So all this, it's a lot of factors that are involved, right? The emotional needs. Also, is this patient under stress? What's going on in his life? Number three, when new complications factors influence self-management. No? Right now, for example, let's say a patient, oh, I feel like I'm having palpitations and now I'm having problem with my visions. Now it's time to educate more and more. And when transition, number four, in care occurs. Now the patient is in the hospital, we're going to transfer the patient to another unit, maybe for surgery or amputation. So it's very sad. So I honestly think that this shouldn't, from the diagnosis to the time the patient returns for annual assessment, we shouldn't be waiting for that. We should keep providing education to the patient in a monthly basis, right? Basically, inviting the patient to for a follow-up. But this is something that insurances, they don't pay for phone calls, nurses phone calls, follow-up phone calls from the doctors. You know, it's difficult to keep up with the patient education if the patient is not motivated to learn also. A certified diabetes care and educational specialist or a healthcare professional with a board certification in advanced diabetes management may provide the diabetic self management education services, right? So sometimes in the clinics, you don't have this special person, this professional with all these credentials and certifications. So basically your provider is the one prescribing, and in 15 minutes or 10 minutes of the provider appointment, they don't have time to go extensively and educate the patient. Okay, dietary and lifestyles management, healthy eating patterns specific to individual nutrition needs, right? Cultural preferences and socioeconomics must be considered. If a medication regimen includes insulin or insulin secretagogue, one class of oral medications that increases the risk for hypoglycemia, then the healthcare team will work together with the client to create a physical activity, food, or medication plan. Okay, so based on the medication, the doctor will, if they have time, right? If they have the specialist in the clinic or the nurse is knowledgeable, will provide all the instructions for the patient based on the food and the medication the patient is taking. So we need to monitoring self-testing procedures as well as understanding the results and knowing what action to take in relation to food, medications, and physical activity. A blood glucose meter is a medical device. So it is your glucometer that patients they need to start using. Sometimes old recommendations were like 3 times after eating, right? A day, after breakfast, after lunch, and after dinner, the 2 hours, right? To double check. Or right now, they are basically because of insurance expenses, they are short and they recommend patients to follow up on their glucose every, twice a day. Medications, you're going to come across patients that are really really motivated and they check the glucose before eating and then 2 hours after eating, so for a total of 6 times a day they go with a finger stick. Medications, the education encompasses details about their medications such as side effects, toxicity, dosage, and storage. Teach back method is recommended. So you teach something and then ask the patient to teach you back what they learn. Problem solving, planning, and preparation on a daily basis is crucial. Planning is crucial. So I am sitting here, let's say on Sunday, and I'm going to write down all the different menus I'm going to have this week. So I'm going to do my shopping based on the list. So whenever you are at home and you feel like you want to eat something, you are not going to find it. Okay, I know a patient that the husband really was worried about her health. So he told her, you're going to stop going to the market. I am the one doing the shopping. So whenever she had these cravings for specific food, especially carbs, she opened the refrigerator and couldn't find anything, only carrots and celery, vegetables. And specific breads, or he bought very healthy foods, so he was cooperating with her. The association of, so basically planning is important. Also the patient needs to know how to solve hypoglycemia and hyperglycemia, right? What to do in terms of hypoglycemia, what to eat. The Association of Diabetes Care and Education Specialist curriculum includes a 4-step problem solving cycle. Number 1, you need to act. Number 2, analyze and evaluate. Number 3, discuss solutions. And 4, learn from experience, right? Reducing the risk is important to consider treatment options for acute and chronic diabetes complications. Toolkits and checklists generally include monitoring blood glucose and blood pressure levels, smoking cessation, right? Food care, and knowing which annual healthcare visits are recommended. But for diabetic patients, I would say you have to go to because the 3 long-term complications, right? You need to follow up with your primary care doctor, get referred to see the kidney doctor, to see your ophthalmologist, to see a neurologist to check your nerves and everything else, right? And also your podiatrist for food care is very important. And also you need to talk to the patient, if the patient is a smoker, to stop smoking. Okay, and if the patient suffers from hypertension, the visit to the cardiology is mandatory as well. So it's a set of doctors that are going to take care of this particular diabetic patient. Psychosocial assessment and care, psychosocial concerns such as depression, diabetes, related stress, anxiety, eating disorders, are cognitive impairment, right? All of these we need to monitor especially stress and anxiety, that can increase the glucose level. Just I know patients that are fasting, and because they are going through a specific stressful events, their glucose reach sometimes 400. Okay, it's just all stress related. I also know another patient. It was I think it was the mother of the patient who was in hospice care, and that particular patient was taking care of the mother. So was the patient was eating in the cafeteria in the hospital in Northwell. They have a very nice salad bar. So she was eating from there. She was taking her diabetic medication, but in the moment the mother, I think, or it was the sister or the grandmother, I don't remember. In the moment the mother was close to pass away, to make the transition, her sugar was close to 500, and she developed like kind of paralysis in half of the face just for that period. After the patient passed away, she went back to normal, but in that moment of stressful events, the glucose reaches almost 500. It's very common, this. So resources awareness, a number of organizations furnish a wealth of evidence-based tools for both the healthcare team and the person with diabetes, such as the ADA, the Academy of Nutrition and Dietetics, and the Association of Diabetes Care and Education Specialists. So medical nutrition therapy. So patient-centered approach. Many people find that diabetes management is challenging. Of course, it's challenging. You see too many factors, many doctors. You need to take care about the psychological factor, the nutritional factor, the monitoring, the side effects of the medication, how to use the glucometer, how to inject the insulin, manage of hypoglycemia, management of hyperglycemia. It's not easy. All people with diabetes should receive a medical nutritional therapy referral to work with a registered dietitian nutritionist, and good luck if the insurance covers for this visit. Yes, it's the truth. For an individualized nutrition plan. When medical nutrition therapy is delivered by a registered dietitian, studies have shown a significant decrease in your A1C levels, up to 2% in individuals with type 2 diabetes, and 1% to almost 2 in those with type 1 diabetes. Of course, if you have somebody who is monitoring you, who's teaching you, and they have the time, and they know how to treat each condition. By the way, medical doctors, your primary care provider, didn't get not even one semester of nutrition in their curriculum. I am telling you the truth. They are not trained to provide nutritional advice. Your doctors, your regular doctors, okay? So that's why we are having this problem. When, for example, a patient that goes to the primary care, the doctor is gonna tell the patient, you have to stop eating sugar. If the patient is having hypertension, the doctor is gonna tell you have to stop your sodium consumption, right? Many insurance plans, including Medicare and frequently Medicaid, cover 2 to 3 annual visits with registered for MNT. So it's 2 to 3 annual visits only, right? 2 to 3. With all these factors, and sometimes the appointments are by phone. Many of my patients are reporting me, I don't find any nutritionist in my area, and they just call me, how are you doing, what are you eating, that's all. Prediabetes. Individuals with prediabetes are those at risk for type 2 diabetes, can decrease their risk of diabetes and CVD by choosing healthier foods and increasing physical activity, again, to promote and maintain modest weight loss of 5% to 10% of body weight. So Mediterranean diet and the DASH diet works very well in order to prevent diabetes. And also during the diabetes phase, the Mediterranean diet is excellent. Now, In terms of diabetes, the primary focus of the registered dietitian is to provide evidence-based recommendations that promote and support healthy eating patterns with a focus on a varied intake of nutrient-dense foods while maintaining appropriate portion sizes, right? So overall goals are to improve diabetes outcomes, to have your A1C, blood pressure, and lipid levels under control, and maintain and achieve a healthy body weight and prevent or delay the onset of diabetes complications. So the registered dietitian considers the overall nutrient intake and balance this with the individual's cultural and personal preferences, and also provides practical daily tools to help with meal planning and takes into account the person's access to healthy foods. That's another issue, right? The financial part. And if the patient is having a busy schedule and they cannot cook or prepare their lunch, right, their food, so the problem is that they are going to start eating from a restaurant in the street food, and that's another complication in the management of diabetes. Additional considerations: the goals of the medical and nutritionist therapy is to meet the nutrition and psychological needs of these unique times of the life cycle, when a woman with diabetes becomes pregnant or when pregnancy induces gestational diabetes. Her body metabolism changes to meet the increased physiologic needs of the pregnancy while battling the manifestation of diabetes. Carefully team monitoring is important, and provide self-management training for safe conduct of exercise, including the prevention and treatment of hypoglycemia and diabetes treatment during acute illness. This disease needs a very close monitoring. Some patients, they get really motivated, they start their diet full salads, and they start increasing their physical activities, and they have very often episodes, or very frequent episodes, of hypoglycemia. And that's also a life-threatening situation because you can have seizures, right? Remember, I mentioned we need glucose in the brain for general brain function. So somebody needs to monitor them. We need to address what they are eating, how to manage the snacks before exercise. That's another part of patient education, right? Total energy balance. Type 1 diabetes most commonly begins during childhood. Okay, normal growth charts are available for this. During adulthood, maintaining a healthy weight continues to be a basic goal. For overweight or obese individuals with prediabetes, working toward persistent and modest weight loss helps to prevent or delay the onset of type 2. For overweight and obese, so we are talking about different, right? For overweight or obese individuals with prediabetes, you need to exercise to prevent type 2. When the patient is overweight or obese with type 2, so the condition is already there, weight loss of 5% or more produces clinically positive outcomes in glycemic control, blood pressure, and blood lipid levels. Okay. So here I want to mention something. There are some patients that because they are having glucose out of control, I told you, right? You're going to have a lot of polyuria, which is a lot of urination, and the patient is gonna become dehydrated. But the patient is losing weight because he's losing fluids. So the patient thinks that whatever he or she is eating is correct because he's losing weight. So she thinks her diabetes is under control, when in fact what's happening is that the patient is losing fluids, right? It's not really losing weight, it's losing fluids. So some of those patients, they stop monitoring their glucose because they lose weight. They see, oh, I'm losing 5 pounds, 10 pounds, I'm losing weight, so I'm not monitoring my sugar that closely because I'm losing, when in fact they are losing fluids, right, to get rid of the glucose. So that's another issue. Additional clinical benefits are realized with even greater weight loss if the patient lose like 15%, as the outcomes are progressive. Some individuals are capable of driving their diabetes type 2 into remission through weight loss and healthy lifestyles alone. I know patients that they stop eating carbs, they are in the ketogenic diet. Everything is related to proteins, no carbs, right? And then what happened is that because they are eating a lot of proteins and high cholesterol, right? Because it's full proteins and they use different type of oils and butter, right? Or cottage cheese to in order to not eat the carbs because they said I need this fat in order to have energy. So they ended up with gallbladder disease. So they have cholelithiasis and they have the gallbladder being removed, cholecystectomy. You see, so it's one or the other. It's basically better to try to make a balance in your nutritional plan. Physical activity improves the cellular uptake of glucose and is fundamental component of glycemic management. Energy intake should equal energy output unless energy loss is desired. Okay, so now we are talking about nutrient balance. There is no specific macronutrient, meaning your protein, your fats, and your carbs distribution recommendation for individuals with diabetes. So the nutritionists who specialize in diabetes-related nutrition therapy to have their meal and macronutrients plan customized for their needs is going to prepare a good plan for that particular patient, right? The guidelines for macronutrient, micronutrient, which is your vitamins and supplements, and alcohol intake provided in box 20.3 reflect the recommendations from ADA standards of medical care. So we are going to go to see the box 20, okay. Box 23, Summary of American Diabetes Association Medical Nutrition Therapy. Okay, let's see the recommendations. So here they are presenting different types of recommendations, and you see a evidence rating. So this evidence refers to that they conducted the studies, and when evidence rating is A, means that it's really reliable. A, B are really reliable. Evidence level E is is not as reliable as evidence A. So let's move to, for example, eating patterns, the category eating patterns and macronutrient distribution. So you have level B, a variety of eating patterns are acceptable for management of diabetes type 2 and prediabetes, reducing overall carbohydrates intake for individuals with diabetes, demonstrating the most evidence of improving glycemia. So less carbs, better glycemic levels, right? And is maybe applied in a variety of eating patterns that meet individuals' needs and preference, right? So diabetics patient type 2 not meeting glycemic targets or where reducing glucose lowering medication is a priority. Reducing overall carbohydrate intake with low or very low carbs eating plan is a viable approach. So the level, also the quantity of carbs, is going to allow the patient to reduce the medication. This is another one interesting. In terms of carbs, the level of evidence is A and B. People with diabetes and those at risk are advised to avoid sugar sweetened beverage, including fruit juices. Yes, those are really bad for diabetes. To control glycemia and weight and reduce their risk for cardiovascular disease and fatty liver. This is a consequence. and should minimize the consumption of food with other sugars that have the capacity to displace healthier, more nutrient-dense food choices. So you have your recommendation, evidence-based A, and the one related to fatty liver is evidence-based B. So you can keep going and reading. I just highlighted the ones with the evidence A and B, right? And you can go and read your summary of American Diabetes Association, right? Let me go back to this part and let's talk about carbs. So the quantity and quality of the carbs food consumed influences the postprandial glycemic response. So postprandial refers to the glycemic level after eating, right? 1 hour or 2 hours. And the ADA recommends a diet that includes nutrient-dense carbs from fruits, vegetables, whole grains, legumes, and dairy products for optimal health. So yes, we have carbs in the fruits. So whatever we have to do is to select fruits that are low in fructose, which is a type of glucose. I'm going to mention fruits that are high in fructose that should be avoided. Your bananas, apples, grapes, watermelon, pineapple, mango, apple, pears. And now I'm going to mention fruits that are low in fructose. Your berries, any type of berries, any color, berry, blueberry, blackberry, raspberry, okay? Also kiwi and papaya. And papaya is good because it helps with digestion and bowel movement. So those three, I didn't mention cantaloupe. I didn't mention, what is the other one that I forgot to mention? Did I mention banana? Yes, but banana is on the other side. It's full, high in fructose. So a good snack should be composed of berries, kiwi, and papaya. Those are the fruits of preference. Oh, oranges, mandarins, full of fructose. Okay, that's a no-no for diabetics. So vegetables, we have to talk about starchy vegetables and non-starchy. Okay, vegetables are good, but none of them. Patients that are, when they hear that they can eat vegetables, they go to the supermarket and buy that bag mixed vegetables with pears, carrots, corn, you name it, right? Green beans, and those are starchy vegetables. Sometimes they are, it's like carbs. It's like eating a potato. You should choose your green lettuce, your spinach, your kale, right? Arugula, your tomato, cucumber, your peppers, radishes, okay, tomato, cucumber for salads, right? Now, for additional information regarding low carbohydrates and very low carbs eating patterns, see the for further focus box. Okay. Starch and sugar. For individuals with diabetes, understanding the difference between starchy vegetables and non-starchy vegetables is important because vegetables, they have a low carbs concentration, such as green leafy greens, vegetables, onions, green beans. Those are non-starchy vegetables. Vegetables that are dense in carbs, such as potatoes, corn, peas, and legumes, are examples of starchy vegetables, right? So that bag in the supermarket is a no-no. Individuals, so if you are getting that bag with your protein, you are not gonna eat. Not going to put a side of rice, right, on top of that starchy vegetables, or potato, or yuca, or beans. No, that's a no-no. So individuals with diabetes do not need to avoid carbohydrate-rich food because they provide an important. Yeah, we don't need to avoid it. So that ketogenic diet is not recommended. Vitamin, minerals, and fibers. Okay, so rather it's important for the person with diabetes to monitor portion size and balance carbs with other macronutrients intake. Okay? Glycemic index. The use of the glycemic index for individuals with diabetes may provide a modest benefit for lowering glucose values. However, there are mixed results of its effectiveness. Personal preference dictates the use of the glycemic index values. So it's not that you suppress the use of, here is the article about low and very low carbs that you can read. It's not about suppressing the intake of carbs, but it's about portions. That's the summary of all. Now, in terms of fiber, there is no reason for these individuals to consume greater amount of fibers than the general population. Current recommendations are to consume approximately 14 grams of fiber per 1,000 calorie, which is approximately 25 grams for women and 38 for men. And that's good to know. Increasing fiber in diabetic diet lowers your blood glucose level, right? Your fiber, what is your fiber? Your vegetables, raw vegetables, your raw fruits. That's your fiber. The type of vegetable I mentioned, the type of fruit I mentioned. Sugar substitutes and sweeteners. Okay, you have your nutritive and non-nutritive sweeteners are safe to consume in moderation and may help individuals with diabetes reduce their intake of added sugar, right? The ones that are nutritive sweeteners are your sucrose, your fructose, your sorbitol, okay? But the ones that are non-nutritive, we have Splenda, Sweet and Low, and those have they are high in aspartame, which is related to cancer, blood cancers. Okay, there is an article here from the American Cancer Society. Okay, and they are talking about. Let me see. Let me see if I can go there. Okay, they are talking about the use of aspartame related to blood cancers. Okay, I cannot open it, but I'm going to give you that particular part of information is very important. So instead, you can use, instead of stevia, instead of Splenda or Sweet and Low, you can use stevia, which is a non-nutritive, but is organic and is natural, okay? So it's very important, stevia, but you have to choose the one that is organic, okay? Protein, there's no evidence that a protein intake differs, is different than the dietary regulation guidelines for the general population and will include glucose control for clients with diabetes. So experts do not recommend excessively high protein intake for individuals with diabetes, especially with diabetic kidney disease because of the ammonia component, right? And because of its necessary stress on the kidneys, because we need to get rid of the residues from the metabolism of proteins. So that is your ketogenic diet, full of proteins, right? Poor kidneys. Likewise, consuming less protein than the general recommendation does not provide clinical benefits on glucose levels, okay? CVD risk or the glomerular filtration rate of the kidneys. Fat, there is no evidence that a fat intake differs from the guidelines for the general population, will improve clinical outcomes for clients with diabetes. Fat quality appears to be more important than fat quantity. Is the quality versus the quantity. So when you buy butter and you select that butter that has like 7 or 8 lines in the ingredients, that is not a good quality. If you want to get good butter, select the one that says salt and cream or milk and salt, period. Those two ingredients, that's it, okay? And that's a good quality. So that's why the patients, they need to learn how to read labels. Mediterranean diet, which is high in monounsaturated fats, are favored over low fat, high carbohydrates diet. Low fat, your low fat milk, your low fat cottage cheese, sometimes they have other different ingredients, and at the end the product is not nutritional, right? Okay, so let's talk about nutrients intake, physical activity, and medication timing. Daily schedule for clients taking insulin or insulin secretagogues. Preparing meals and having a backup plan help to prevent or minimize hypoglycemia. So if you're going for exercise, planning, you need to plan before. I'm going to do 30 minutes, so I'm gonna get a banana before that. Okay, just an example. Um, a high stress event caused by any source, injury, anxiety, fear, pain, brings an adrenaline epinephrine rush. So you see, as I mentioned before with the patient that I know that was having a family member in hospice, the fight or flight effect counteracts insulin function and contributes to a glucose response. So physical activity and glycemic management. So especially both basal and bolus insulin together must balance their physical activity with their medication and carbs intake. So number one, aim for normal glucose levels before physical activity. So at 11, I'm going to do my training for the New York Marathon, right? So you need to have normal glucose levels before that. If glucose levels are less than 100, the patient needs to ingest 10 to 20 grams of carbs before exercise, right? Could be an apple, I don't know, crackers, a banana. If the patient is having hyperglycemia more than 200, people with type 1 diabetes need to check for ketones, avoid moderate to vigorous activity with high levels of ketones, right? And don't go for the training of the New York Marathon. But use caution with elevated glucose levels, even in the absence of ketones. Now, also monitor glucose levels before, during, and after physical activity, right? Hypoglycemia also manifest as patient will have be cold, sweating cold. So if a patient is going to practice activity in this weather, that could be patient be confused between hypoglycemia, right, symptoms, and the sweating in this weather, which is going to be cold. Okay, so think about that too. Monitor food and fluid intake. Consume added carbohydrates as needed to minimize or prevent hypoglycemia. And also carry fast-acting carbohydrate sources that are easily available during and after physical activity. So there is a table 20.6, for example. Very interesting table, right? So if the activity is going to be moderate, it's going to be 30 minutes, okay? Usually not necessary unless blood glucose is less than 100. You don't need any carbs. If the activity is going to be 1 hour, you can bring one small apple, half banana, half peanut butter sandwich, 2 tablespoon raisins on one energy gel. If the activity is going to be strenuous, lasting 1 to 2 hours, bring peanut butter and jelly sandwich, one large banana, granola. Here, this table is very interesting and very helpful. Okay, very interesting and very helpful. So we are going to stop here, okay? And when we come back, we are going to talk about the carbohydrate counting. And that is going to be the last part of this chapter 20. Thank you.